As everybody's coming in here, I'm sure all of you know already, but we can request topics if there's something that you are interested in. We actually have a form that's on our website that you can go to and fill in. But you're also more than welcome to email myself or Dr. Cruz. But if you have any suggestions on presenters or on topics, please feel free to let us know.
Yep.
And so today's Family Medicine Grand Rounds for November 11th, the event ID number is 316047. That is the event code you'll need for today's session in order to claim your CME credit. And for today's session, we appreciate you muting your microphone as the presentation begins. If you'll please be attentive to our presenter, be engaged in the session, and complete and submit the evaluation form. I'll be putting that information in the chat box for the evaluation towards the end of the presentation. As far as questions go, Dr. Rodriguez has mentioned, if you'd like, if you can put those questions in the chat box, we will be answering those at the end of the presentation. And so this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central AHEC, and our mission statement is to invent a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. CME transcripts are accessible by going to the CME website. You can find the information on your transcript by going to their website and clicking on My CMEs, and then you can open up your transcript once you sign in there. So if you have questions, please feel free to call or email them. Also, be sure that if you are a member of the AAFP, you can contact them and you can claim credit for this presentation through them. Dr. Rodriguez has no financial interest to disclose for this presentation today. And so she is going to be presenting for us strategies for providing effective feedback in medical education. So I will let her go ahead and get started.
Hi, everyone. Again, my name is Michelle Rodriguez. I am a product both of the medical school here as well as the residency program, if you don't know me, and I'm now at faculty. I practice over family medicine over at the Mark, and I also work as assistant clerkship director along with Dr. Andry. Okay, so our presentation today is about strategies for providing effective feedback in medical education. The word feedback for some, maybe even most people, usually arouses a little bit of discomfort and sometimes negative emotions. And I remember for me, it certainly did so, and especially the first time as a resident, I had to precept students, and then again as an attending. And so in exploring why, I think some of the times the reasons for that discomfort is that we just don't know enough about what's expected of us as educators providing the feedback, don't have good guidelines or strategies or guidance. And so my hope is that if there are gaps, educators out there that are struggling with some of these issues, this presentation will help provide you with information you need to become a more effective evaluator. So for our specific objectives, we have, at the end of the session, you should be able to discuss the common challenges and barriers to providing feedback, explain several approaches to providing feedback, list strategies for effectively delivering feedback, as well as identify common topics for providing feedback to medical students, learners, and positive approaches to each. Now, while this presentation is tailored mostly to educators of medical students, certainly the concepts discussed throughout can be applied to different types of learners, including, for example, residents, as well as pre-med students, because occasionally we will see those come through the clinic. So let's start by defining feedback. According to Merriam-Webster, feedback is the transmission of evaluative or corrective information about an action, event, or process to the original or controlling source. How about in the medical field? Is there something a little more specific? Of course there is. Here are two definitions, pretty similar, but that are helpful, a little more applicable to our setting. And they define feedback first as information describing students or house officers' performance in a given activity that is intended to guide their future performance in that same or related activity. The next one is the iterative process wherein a learner attempts a task and receives critical analysis about his or her performance from the supervisor. So let's turn now to why is feedback important. In our medical education system, we are now in a competency-based approach era. And what that means is we evaluate our learners by determining whether they have reached certain milestones before advancement. And especially in the clinical setting, when literally in clinic, the most important thing to helping them evolve as future physicians is to provide feedback. Feedback is essential to enabling the learners in this path by reinforcing good performance and providing the basis for improvement and remediation when needed. Interestingly enough, medical students and residents have reported that feedback is useful in their education. And there's a great study by Bradner and all, and they interviewed 300 third-year medical students who rotated through family medicine at VCU from 2012 to 2014. And they sent them surveys. One of the questions was for them to complete the following sentence. My preceptor contributed to my learning by, and feedback was pretty high. When they sorted all the responses by themes, the top three were, number one, autonomy, which we do see a lot of in our clinics, thankfully. Two, stimulating critical thinking. So maybe pimping and done in the right way is really perceived as very useful to the students. And then number three is feedback. So where are we hitting the problem then? Because we do have medical students and residents that report they get infrequent and or ineffective feedback, whereas we have educators that are reporting frequent and adequate feedback. So we've got a big gap there. We've got a problem that we need to figure out. So let's talk about common barriers to providing feedback, and more specifically, effective feedback. Number one is unclear purpose. And part of it is for the learners and part of it is for the educators. Do we understand what we are providing feedback on? Do the learners understand what is the purpose of feedback, how it really plays into their development and advancement in their clinical skills development and as well as in their medical education overall? The next one is a lack of appropriate time or place. And this is logistics and does require a little bit of planning, but if our clinical sites don't typically change, then we do it once, prepare a space to provide feedback, and we're done. The next one is lack of confidence by the educator in his or her observations. Another is lack of knowledge how to translate observations into specific, non-judgmental and constructive feedback. Another one is one-way flow of information, and particularly when that tends to be more of the corrective feedback without anything else during that feedback session, it can oftentimes be interpreted as a negative situation and irregularly evoke negative emotions in the learner's mind, and also color their sort of pre-mindset for the next feedback session. Another barrier is lack of longitudinal relationships. Studies have shown that having a longitudinal relationship can improve the feedback relationship. And part of that is building a trust and rapport, which is very essential to having the learner in the right mindset and trusting that the educator has their best interest at heart when giving the feedback. Another one is insufficient, irrelevant, or poor quality feedback. And in some cases, you can all three. And as much as we all love to hear, man, great job, that's actually insufficient, I suppose relevant, depending on what you meant by that. But if you don't communicate it, it's not helpful. And definitely poor quality feedback. So unless that student or learner was 100% perfect and truly needs zero improvement, there's zero areas for improvement, good job is really not good enough. We'll come back to that. Another barrier is minimal or no formal training on providing feedback, and that's what we're trying to help do today. Another is failure of learners to recognize, internalize, or act upon feedback. There's an interesting study in which educators were trained on a particular feedback strategy, and the study looked at the quality and quantity of their feedback after the intervention. Both had improved, but the students didn't perceive an improvement. And part of that is making sure that the learner is in the right mindset to understand that what's coming next is in fact feedback. And then the last one is negative emotions. And as we've discussed, it can occur both on the educator side and on the learner's side. For the educator, sometimes it's fear, discomfort, desire not to upset the learner, especially when you're talking about feedback early in a rotation and you know the learner is still going to be at that site for a few more weeks. From the learner, if they've had a negative experience, they can associate with feedback emotions like embarrassment, anger, feeling unheard or unfairly criticized. All right, so before we jump in a little more into strategies, I do want to talk about categories of feedback. So there's various ways of categorizing types of feedback, and these are two really good ones because they're especially helpful when we're looking at precepting students, residents in the clinical setting. There's informal feedback and formal feedback. Informal is usually verbal and ongoing. Formal is the more structured assessment where the learner is being measured against a standard and is oftentimes involved in the actual grade a learner is getting. Similarly, formative feedback and summative feedback are very similar, very similar distinctions, useful in promoting learning, and that's for the formative portion. For summative, it's again evaluative, and you're measuring performance against a standard. So when you're thinking about what does that mean for me in practice as an educator, especially for our residents, and it's especially challenging for you because you are in both roles simultaneously when you're working with a medical student, that means that the precepting you're doing, that constant contact with the student, when you provide feedback in those scenarios, that verbal feedback, that's the informal or the formative portion. When you stop at the end of the rotation to fill out those 145 surveys, that's when we're doing the more formal, the more structured and summative feedback, and that will be incorporated into the student's grade. So the informal, the formative feedback that's on an ongoing basis, is that necessary? Absolutely. And why? Because imagine yourself in a 6-week rotation, and at the very end of the rotation, you get a feedback form from the evaluator, and it says, this student failed to every single time give me the 7 elements that are expected in the history of a complaint of pain. Wow. And it says consistently. If we'd had that student receiving regular feedback throughout in a more informal setting, like the feedback we hope you do in the 1 Minute Preceptor or the micro skills at the end of each clinical encounter, then they would have had a chance to identify that and work on it throughout the rotation and hopefully avoid that kind of comment at the end, because our medical students want to learn and grow and they want to improve. And of course, they don't want a bad grade. All right, so the goals of feedback. What do we, as the educators, want the learners to know? The students should come away from a feedback session with an understanding of what went well. What did they do that was good? What did not? What should be continued in terms of their behaviors or actions? What should be stopped? And what should be added? In addition, another goal of the feedback session is to make sure that student has a plan for improvement if there was an area identified that really does need improvement. Now, there are a lot of different approaches you'll find in the literature, and I'm going to focus on 4 in particular. I don't think any of them is flat out wrong. I think each of them has their place in medical education, in the educator-learner relationship. But in the setting of precepting students and residents in the clinic, there are 2, my preferred 2, and I think after we talk about them, you'll see why, approaches. So the first one I do want to mention is the one-way review of performance. Oftentimes it's strictly corrective, and it focusing on an area of improvement. Now, you might think, well, from what I've heard so far, she's going to say that's awful. There's no room for that in medical education. That's actually not true. And we can see multiple places where that might be the appropriate approach. And in family medicine in particular, or family medicine in the outpatient setting, certainly we have inpatient setting, but in the outpatient setting, which is when we more often than not see our students, the area where that probably is the most appropriate is when you are supervising them doing a procedure and they're doing something incorrectly. Now's not the time to go through the 5 micro skills and get a commitment, get proving evidence, give them positive feedback to gain their trust and promote rapport. This is the time when you tell them, hi, so I see that you have the silver nitrate on the healthy skin. That might not be good. So let's move that back into the skin that we're trying to actually treat. That's a time where this is absolutely appropriate. Another approach is called a feedback sandwich. And you'll see that phrase feedback sandwich used for a couple different approaches, but this is probably the one that is most commonly associated with the concept of feedback sandwich. That's where you put a corrective feedback comment between 2 other positive feedback comments. So your positive feedback comments are each half of the bun, and the corrective is sort of the meat in the middle. Again, that might have its place. And somewhere where that might have its place, and sometimes even in the clinical setting, the outpatient precepting setting, that might be when you have a student at the very beginning of the 3rd year and they are very timid. They're really having a little trouble just kind of getting things out and really engaging and understanding their role. That might be a point where you're still working on positive and corrective and building rapport and trust, but you're taking on a little more of the speak until they get comfortable enough and you can have that 2-way dialogue. The next approach is really the beginning of our 2-way options for feedback, and it's called ask, tell, ask, and you'll see in some of the literature referred to as Pendleton feedback. And it's when you ask the student what he thought about knowledge and performance at the beginning of the feedback session. And that's where you say, hey, you know, what went well? What do you think? Then you tell the student what went well. It might agree with what they said, or you might have something else that's even better. And that's also where you identify when you ask them, what do you think you could have done better? If they identified what you did, great. You can just continue on there. But if there's another area you want to focus, this is where you give it to them and discuss how they can improve their performance in that area. Then you go back to the second ask and you're going to say, what's your plan? What's your plan to work on this? What's your plan to move forward in this area? And you listen. You listen. Take a few seconds to listen, and then if you have any recommendations on how to modify their plan so they can move on to the next level, then that's where you would do so. This last one is for the more sophisticated learners. So I can totally see this when you're precepting a 3rd-year medical student that's at the end of their academic year, or when you're talking about residents that are further on in their education. And this is where you're actually shifting the majority of the whole concept of feedback to the actual learner. It's called agenda-led, outcome-based analysis feedback. You're gonna get the learner's agenda. What do they want out of this session? What areas are they focusing on? What are their intended outcomes? So you're getting that from them. Then you're gonna encourage them to do their self-assessment and self-problem solving. And the whole concept is you are promoting this skill of self-reflection that as family medicine physicians, we need lifelong. And it's focusing on trying to achieve a desired outcome by using a set of skills. And absolutely, you're gonna step in when you need to. You're just shifting a lot of that over to the learner. So how does this fit into the micro skills, the 1-minute preceptor? If you've heard me talk before, odds are you've heard at least one of the presentations on this. If you haven't, then I'm going to give you a brief introduction. So the 1-minute preceptor, the 5 micro skills, is a very systematic approach to precepting a student in the outpatient clinical setting. And despite the name 1-minute preceptor, truly it usually takes 2 to 5 minutes. But it is a very efficient way. And if you do follow all the steps, it is almost guaranteed that you're going to be able to do so efficiently, and that student is going to walk away with helpful information and a helpful roadmap on how to improve. So number 1 is going to be get a commitment. That's when you see the student pause, and usually at the beginning of the 3rd year of medical school, it'll be right after the history and the physical exam. Then they'll look at you like, okay. And that's when you're like, okay, What's the assessment? Or what do you think is going on? Or what's on your differential? Or how would you evaluate that? Step 2 is going to be probe for supporting evidence. You're going to ask them to go back to the information they have already and provide you evidence of what their answer to number 1 was. Number 3, based on their responses to number 1 and number 2, you're going to pick one point. If you have more time, please feel free, by all means, teach more. But we encourage you to pick just one point and teach on it, whether it's pointing them to the guidelines, pointing them to a resource, or giving them the answer right there. And then 4 and 5 are about feedback. Typically, I recommend giving the positive first and then giving the corrective. But my hope is that this is in the context of a two-way dialogue. But how you choose to approach these are really going to depend on the relationship you may already have with that student and where they are in the learning process. So you're going to tailor that to the situation that you're in. If it is your first encounter with a student, then I do strongly encourage you to focus on the positive first, because you don't have that longitudinal relationship with the student. You do want to work on building trust. You want to make sure that you're not just focusing on weaknesses and areas for improvement, that you really acknowledge their value and their work with the patients, the things that went well. All right, so now we understand what feedback is, the different types, where it fits typically in the precepting model of students and residents in the clinic. So how do we deliver that feedback effectively? There's several different guidelines, and I'm going to cover 12, and I left the last 2 in there even though they don't quite directly apply to the individual preceptor, but they are important to keep in mind. I want you to keep in mind because each one of us does play a role ultimately in the last 2. But let's start with the first 2. So number 1, establish a respectful learning environment. This is largely about logistics, making sure you're delivering the feedback in an area that's as private as you can have in the clinical setting. Sometimes we don't have the space to dedicate an entire room for this. The other thing you're going to want to do is look at yourself and be prepared for this. Consider your tone, making sure you're being compassionate. Consider your interpersonal skills, your communication skills, and try to be even-handed. So you're focusing both on strengths and mistakes or corrective areas for improvement. Number 2, communicate goals and objectives for feedback. So some of this might occur if you're the person to orient the student to the clinic at that very first session. Some of it might occur at the beginning of a half-day session with the student that you have. But what does that mean? You're going to orient the student to the work environment. Let them know where they fit in the workflow of patient care. Then you're going to clearly state the goals and objectives of the learning experience. What's their piece with the patient, and what are you hoping for them to learn? You can be as specific as you want if you think it's about history, physical exam, developing assessment and plans, anything else you may want for them. But I strongly encourage you to get their input. What do they think they need to work on? What do they want to work on? Then you're going to provide expectations for what the learner is expected to achieve, and that's related to the previous one. And then before you ever deliver feedback, before they go into their first clinical session, you're going to want to explain the feedback system in advance. So you're probably going to want to give them a 10 to 15 seconds description on what you're going to do. After the clinical encounter, we'll come back here, we'll have a little conversation about what happened with the patient, learn some information, and then go on and discuss some feedback. Number 3, base feedback on direct observation only. This does not mean you need to be in the room with the student at every single encounter, but when you are making the comments on what they're doing, make sure you're not assuming what happened in an area where you weren't. So if it's a really history that goes off on a tangent, then you're not going to talk about it in terms of their interaction with the patient so much as what the information they collected and the way they presented it. You're also going to want to give timely and regular feedback. It gives the learner a chance to improve, remediate before the final assessment. We talked about that a little bit earlier. So we strongly encourage every preceptor to try and give the feedback, or do the entire microskills, but especially give the feedback after every clinical encounter. The information will be fresh in the student's mind, fresh in your mind, and it also gives them a chance to evolve during the course of the rotation. Keep in mind that we, for medical students in particular, and when I say we, I mean Dr. Andrew, myself, and sometimes Regina, we touch base with the medical students at the midpoint, and it is very helpful, and we encourage them by having them fill out a form for them to have gotten at least some feedback from the preceptors that they've worked with in the previous 2 weeks. And I strongly encourage you to start the session with a learner's self-assessment. This helps ensure that it's not you just talking to them, that it's a two-way conversation. Getting that engagement does so much. You'll see the students trust a little more. You'll see them be more invested in what's happening in the entire feedback process. It can also soften the perception of harshness. Even though we don't mean to be harsh, it may come across that way, and also be seen as more instructive. Next, reinforce and correct observed behaviors. You're going to focus on specific behaviors and actions followed by an explanation or an exchange, depending on what's appropriate, on why it was positive or incorrect. You're going to use specific neutral language focusing on performance. So for example, saying, wow, I thought you were really rude with that patient. That's going to hurt, and that's a little bit judgmental, and it still might not be very helpful because they may not be sure what was perceived as rude. Hopefully you don't use that language without having some explanation behind it. Something more appropriate would be to focus specifically on the body language. When you were standing over the patient, as you were talking to the patient, I saw the patient lean back, which made me feel like the patient might have felt a little intimidated by that. Your tone was very loud, and that patient is very soft-spoken. I think she might have felt a little overwhelmed by that. Or focus specifically on their word choice. Again, you're going to want to focus on specific performance, providing clear examples, and in that process, get their thoughts on how they need to change, and if they don't have anything, make those suggestions yourself. Keep this a two-way conversation. After that, you're going to confirm your understanding and facilitate acceptance. Ideally, you provide positive feedback. The student immediately connects with you, and they're so receptive for that corrective feedback. You give the corrective feedback, and the student implements immediately. Next time you see them, they improved, and it's perfect, and there's no emotions involved. The sticky emotions, they're not there. That's not always the case. I ask that all of you preceptors make sure that there is time and space in your mind for a potentially emotional reaction. It doesn't occur often, but we do see it, and make it okay for them to express that. You can give them some time on their own and come back, circle around, and try to close that loop on what happened and why they felt that way. Things that I encourage you not to say, and quite frankly, I've never heard by any of our faculty, but I'll mention here because I have heard from other faculty, things like, you need to toughen up. Oh, wow, you can't carry that attitude around. You'll get chewed up in our business. Not very helpful. And it's probably going to make them feel worse and even less receptive to feedback. All right, so the last 4, action plan. You're going to want to ask the learner for his ideas on what to do next to improve, and then you're going to provide your thoughts on that. After the session, we want you to go back and do reflection on your feedback skills. What you did well, what didn't go so well, what did you not anticipate? Do you need to modify your approach, your own tone, your own interpersonal skills? Now, the next one is sort of an institutional recommendation: create staff development opportunities. That's why I'm here today, and I've done several different sessions over the course of the year about interacting with learners. The last one, make feedback part of an institutional culture. So obviously, institution-wide, we want to make sure that that's being promoted and there's policies in place, but every individual preceptor should be doing their part, and they do so by regularly engaging feedback, making it a positive and instructive experience for the learners. So regular and effective is very important to contributing to this institutional culture. Okay, so when I have given other sessions about precepting students, a lot of the questions I get back, wow, this is great information, but I still, can you give me some examples? At the end of the session, I'm really lost and I'm tired, and sometimes I can't even think of something to say. I'm just like, wow, great job, or, oh, okay, we'll work on that tomorrow. So I'm gonna go through and focus first on some examples of really specific and effective feedback that reinforces specific things that are done, and then we'll go back and talk about some corrective feedback, ideas and examples that might help you structure future corrective feedback. So this is on the positive side. I've got 6 examples. Number 1, you obtained a focused yet thorough history that exposed the patient's financial concerns, which in turn could affect the plan. In time permitting, you can explain, if you provide the patient with a plan that they cannot afford, you are setting the patient up for failure and potentially eroding the trust they have. And you may or may not have the time for that. And some of that might be really obvious, but if you do, be a great opportunity to throw that in. You provided a thorough differential diagnosis that sorted the possibilities by likelihood. Your plans were evidence-based and tailored to the patient. And it's wonderful when I have a student that'll say, hey, based on this article or this guideline, this is my thoughts on what we should do for the patient. Next, you correctly identified the first-line treatments for the diagnosis. So they did their homework. They were aware of what's appropriate in that situation. Your note was succinct, organizing a lot of information in an easy-to-read manner. Your note covered all the problems addressed in this visit. So in none of those did you have sort of these vague, they sound good, but they're really vague sort of adjectives: good, great, nice, helpful. It's really, really specific. And at the end, you can type, wow, I think you did a great job. But by that point, you've given them what they need. They need specific. So let's switch to the corrective feedback. And this is, I think, where everybody struggles a little bit. And still, quite frankly, I do. And so a lot of times I have to sit and think, okay, what areas should I be looking for with this student in particular based on my experiences with him before? And then how should I approach my next session? So common areas for improvement: time management and agenda setting are huge, especially when you're talking about first-year residents or MS3s that are at the beginning of their academic year. This is really hard. They want to go in and have these fantastic long conversations and get the patient's entire stories. We just don't have that time. And so these are almost always areas for everybody to improve at the very beginning. Next is focused interviewing, review of systems, and physical exam. We all remember a student or a resident who's gone in and gotten a ton of information that wasn't necessarily needed. And of course, that bites into time and potentially can set us off on rabbit trails. Confidence to deliver assessments and plans. I still see students that kind of pause, or if they give me an assessment and plan, they're still very timid about it. Another area is structuring the assessments and plans, and that's huge, especially in the beginning of their clerkship year. Supporting evidence, making sure that they're just not reaching a conclusion, but that they have some facts that support that conclusion. Rapport building, and this is in terms of the student trying to spend some time to build rapport, and especially with those of our patients that tend to be a little more challenging, but which of course the student is going to encounter probably throughout the rest of their career. And then if you see specific deficiencies in their clinical skills like history taking, physical exam, assessments, plans, notes, and absolutely that's an area for improvement. Knowledge gaps, that's another potential area for corrective feedback. And professionalism. Hopefully you are rarely, if ever, seeing this. And certainly if it's an egregious professionalism violation, we encourage you, especially with medical students, to reach out to us and let us know so we can make sure that student gets back on track. But it may be an area that you may want to provide the student some feedback on. So let's talk about examples of corrective feedback. These are a little longer because, of course, you want to make sure they understand what's going on. So your plan did not include a referral for a diabetic eye exam, which is an annual screening for diabetic patients. You can review ADA guidelines on diabetes diagnosis and management to understand what routine screenings are appropriate for diabetic patients. Another one, you included cholecystitis on your differential, even though the only pain and tenderness she reported and has on exam is in the left lower quadrant. This was inconsistent with that diagnosis. Work on tying your physical exam findings to a differential diagnosis to help refine the list. The assessments contained repetition of details from the history and problems were mixed up. Organize your assessments and plans by problem, avoiding repeating information contained in the HPI or exam. Those are really, really specific. This one is I've said this more often than not. Of course, I heard it too as a student early on. You spent 45 minutes with this patient and it seemed mostly due to addressing all 15 of her concerns. For complex patients, practice agenda setting at the beginning of the appointment by asking the patient what concerns they have, reviewing topics you want to cover, then prioritizing and agreeing to the topics to be covered in that visit with plan and follow up for remaining concerns. Now, this one in particular can be helped if you have done a huddle with the student beforehand and give them a heads up on the patient. And particularly with a complex patient, you may have already provided them some direction. But still, we do see this pretty frequently. Another one, practice delivering your assessments and plans during your oral presentation for each patient you see without prompting, without that, what do you think is going on? All right, so we've given you a lot of tools today, a lot of information, and in summary, feedback in the clinical setting is essential to the growth of the learner, yet various obstacles make providing effective feedback challenging. The selection of feedback approach should be based on the circumstances and the learner's level, and implementing the recommended strategies can facilitate providing effective feedback. So these are the references to the information contained in. And any questions or anecdotes, especially if you have any interactions with learners that were challenging on the feedback side and you have some thoughts on what happened there.
Anybody who would
I
like,
actually had a quick question.
Mhm.
Just when it comes to, I guess maybe, um, um, pers- uh, for lack of a better term, like personality feedback, like if maybe a student like talks over you a lot or just something like that, I guess how to go about doing that in a tactful way that doesn't seem, I guess, like a personal attack. Because I noticed that even as a student, you know, some of my colleagues are a little bit more, um, um, I don't know what the word is other than like know-it-all-y and things like that, which I think we all are a little bit guilty of in this field. But how do you provide feedback to be like, hey, you know, be more of a team player? Like, because I just feel like maybe that, I don't know. That's my question.
Okay, absolutely. So that is, you know, it's challenging not to comment on someone else's feedback, and it hurts a lot. I mean, personality, and it hurts a lot when you hear a comment on personality. So my recommendation, every personality, we're only going to feel it because it's manifested in wording, in actions, in interactions. In other words, there's going to be some manifestation of the personality. And that's what I encourage you as an educator to focus on. So I have had patients, learners that are what I think is a little bit rude to the patient. But how does that manifest itself? It manifests itself as them speaking louder, cutting off the patient, their body language, their tone aside from volume. And so that's what you're going to focus on. So saying something like, you know, I need you to be a better team player isn't as helpful as saying, in this environment, we work in teams. And so when the MA does come and ask you a question, the MA is a very important, valuable part of the team and may be providing you some really important and urgent information. And they have key phrases for when to jump in and let us know it's an emergency. For example, I am concerned X. So it is extremely important that in these circumstances, you turn around and give your full attention to the member of the team that's talking to you and get that information and decide if you need to act on it. You know, I mean, and that's just one example. You really could focus it on whatever aspect of the behavior lets you know that the person has that personality. Is that helpful?
Yes, it is. Thank you so much.
You're welcome. Any other questions, comments, anecdotes?
I have a question.
Mhm.
You said that it's best to give the feedback immediately after the clinical encounter.
So,
Frankly, in the middle of the afternoon, when you have multiple patients to see and the medical students may be seeing 2 or 3, is there any effort or value lost by having the feedback session at the end of the afternoon?
So I absolutely agree. There may be times when you cannot do it right after the clinical encounter. And I'm sorry, that was my hope to bring that up, and I completely forgot, Dr. Hans, so I'm glad you mentioned this. Especially in those sites. We have sites where they see 12 patients in a half day. Stopping to do that feedback after the specific clinical encounters can seriously interfere with the workflow. But circling back at the end of the half day with the student to do so is still very important. And it really needs to be at least at the end of the half day. Thank you. Thank you for that.
Michelle, I'd just make the comment that a lot of education, especially in the clinical setting, takes place within the context of relationships. So, having a good professional relationship with the student means that it'll be easier to give the feedback and easier for the person to accept the feedback, I think.
Absolutely. And so there are actually studies that have looked into this, the value of the longitudinal relationship in the feedback relationship. And having a longitudinal relationship is great, except that we don't have that very often in our very short bits of time with the students. We only have them for 4 weeks, and we may only see them 3 or 4 times in that entire time. But there are ways to establish that rapport, just like a patient, to establish that rapport in a really short time frame. And trying to do so before you get to that feedback portion is important, because you're communicating that you value that student's input. You value the student's input. You understand that they're part of a team, and that when you get to the point of providing, especially the corrective feedback, it's coming from a place of you wanting to help them in their educational development. So absolutely, the relationship is extremely important.
And just another additional comment. I know the talk was more about giving feedback than accepting feedback.
That's a whole nother talk.
The two are very interrelated, and your answer to Jasmine's question at least touched on it. So it is, I think there is a normal angst about you give feedback and then the student comes back with some sort of a disagreement to that. And so I just think, whether it's yourself or whether you're dealing with somebody who's pushing back on the feedback, I think it's important for the person getting the feedback to just keep in mind, they may not agree with it, but they did leave one person with that impression. So they just need to contemplate that. That's important for their growth. Whether they end up deciding that they don't agree, that the teacher's off out of bounds on that one or whatever, somebody was left with that impression. I just think that's the perspective that we need to keep and that the students need to keep.
Yes, and it does happen. So we get, most of you probably know by now, especially for the medical students, the preceptors, the students are sent 145 surveys on the preceptor's performance as educators. And so a lot of times we'll see, I don't want to say, it's actually not very often, but we do see comments like that about them disagreeing with some feedback on them. And so Dr. Andrea in the orientation does prepare the students to understand that they're going to have feedback. And then from our perspective, helping establish a good relationship with the student ahead of time is helpful, but absolutely be prepared to get that. At some point, you're going to get feedback on your feedback that, may be a product of them not receiving the feedback in either the spirit that you intended or just flat out disagreement with it. And that's okay too. Any other comments, questions, anecdotes? All right, well, I thank you all very much for your attention, your engagement, and the questions, especially at the end. Have any questions on this or have any suggestions on faculty development sessions in particular, please feel free to reach out to myself or Dr. Andrea, and we'll definitely try and get some of that addressed.
Just one final point. So then Nicole's asking us to give feedback on this discussion. So this is like a final exam, right?
This is, I'm going to go through each one and say, no.
Go through each one and see whether we know how to give feedback, whether we learned something from the talk.
I don't want to see any good jobs. No, I'm kidding. I'm happy. All right. Thank you, everyone. I really do appreciate it.
Thank you very much. Everybody have a good afternoon.